back. I'll show, we saw this slide already, but I would like to make a few points on this. As you can see here, what we define as CR today is basically -2. And you can see it here. This is what we see with serum tools. The concept is more you go down, longer you require to go up. And if you give a continuous treatment, you delay this coming back of the tumor. So the first issue is, my point is, probably there is not so much difference between IMiD and proteasome inhibitors. You can see here from those two studies, in terms of progression-free survival, the advantage is impressive, is around 12 to 19 months maintenance versus no maintenance. Once again, residual tumor, delay of the regrowth of the tumor. Also, if you see it here, and we just discussed it a few minutes ago, you can see here with RD. RD continues, RD 18 months or MPT 18 months, you stop the treatment, curve start to diverge. In MPR, the story was exactly the same. The moment you stop, the curve start to diverge. With bortezomib, the same story. The moment you start treatment, you start to see the differentiation in terms of progression-free survival. What about overall survival? Has been a discussion, is inconsistent. Some studies are saying yes, some studies are saying no. This is a published meta-analysis of continuous versus fixed duration. And you can see here that thalidomide, lenalidomide, bortezomib, with, of course, some studies that are giving contradictory results, are on the majority showing a benefit in terms of overall survival. But once again, to say that A is clearly superior to B is not so easy. Here is the last one, and this is this is carfilzomib. It's very interesting to see those two studies. Carfilzomib has been given as KRD for 18 months. RD has been given continuously. You stop K at 18 months, curve went back together. You give here KD continuously versus VD, the shape is completely different. So this is the proof of the opposite. The moment you stop it, you start losing something in terms of remission duration. Has been shown this, I don't want to go in many details. What I would like to say is, if we have to make a comparison, bortezomib, from an efficacy point of view, I wouldn't say that it's clearly superior or inferior to IMiD. Has two problems. One, injections. Every 15 days you have to go to an hospital. To take a pill and go to the beach for a month is much better. On the other hand, you have some peripheral neuropathy issue that is still there. Even if you give it every 15 days, peripheral neuropathy, as it is for thalidomide, is a sort of side effect. So these are, in my opinion, the two major side effects of this approach. We are now looking at carfilzomib lenalidomide. I can only show the study that is currently ongoing. So another option could be the combination. We have seen bortezomib, thalidomide, carfilzomib and lenalidomide without any issue in terms of peripheral neuropathy may represent an alternative, although the infusion of carfilzomib is not that friendly on a long-term basis, because you have to think about 4 infusions per month. What about the oral proteasome? This might represent probably the real competitor to lenalidomide, in my opinion, because it's oral at the end of the day, and this is what is very important in terms of continuous therapy. Where is the problem here? 21 patients today. So evidence is suggestive, might be interesting, but honestly, we do not have enough data to say something on Ixaxomib. We have to wait the two major randomized studies that are currently ongoing, comparing Ixaxomib maintenance versus placebo in both non-transplant and transplant-eligible patients. Then, which is early, so take it as an early. Diarrhea, 50% is probably something not that friendly. Certainly in terms of peripheral neuropathy and hematologic toxicity, less. The main issue probably is coming from GI toxicities. These are the two studies that are currently ongoing for maintenance versus placebo. So the conclusion is the oral proteasome is a plus because it's oral, has some GI. We certainly need major evidence before drawing definitive conclusion. What about lenalidomide? I'm not saying too much, has been said many things already. What I would like to highlight here, that is today, to some extent, with all the risk you run, the most friendly approach we have, because beside neutropenia, that is certainly relevant and need dose reduction, we do not have major peripheral neuropathy, we do not have major non-hematologic toxicity. Of course, if the treatment is a treatment and something is there. So from a friendly point of view, is probably the best available agent and is once again oral. Now, what about the evidence? The last thing why I'm in favor of lenalidomide today is that we have major evidence. We have several studies, all clearly showing benefit in terms of progression-free survival. And once again, I want to stress the concept that here we are talking about 12, 18 months. We are not talking about 3 to 6 months. So the difference here is around 1 year of remission prolongation. And this is another meta-analysis. What can I tell you? Is probably a matter certainly not so big, 1,200 individual patients. We had this type of discussion because the discussion has been always, well, you give a continuous therapy, then at relapse, you get a more aggressive disease. And therefore, we started to evaluate the PFS1, that is from therapy to first relapse, versus the PFS2, that is from therapy to second relapse. So putting together not only the first remission, also the second remission, because if I gain too much in the first remission and I lose too much in the second remission, this is probably not so relevant from a clinical point of view. And you can see here that once again, in PFS1, the difference is 16 months, and in PFS2, the difference is once again 16 months. So what you gain in the first remission duration is maintained in the second. So it's not so true that the continuous therapy is creating a more aggressive relapse. Of course, in thousands of patients, single case, everything can happen. So my conclusion is that lenalidomide is showing extensive efficacy. So the major plus for lenalidomide is an oral drug, mainly neutropenia as a side effect, extensive data, both in terms of progression-free survival and overall survival. Ixaxomib, the oral proteasome inhibitor, is certainly the future major competitors. Today, we just have a phase 2 study, too early to say anything. The GI toxicity might represent an issue, and that's why, to some extent, I'm still today in favor of lenalidomide. I personally believe that there is a limited value for an intravenous drug. We can say whatever, but you know, if I'm thinking today, as I was saying before, after autologous transplantation, the PFS is more around 5 years. Should I have to go to a hospital twice a month or 4 times a month for 5 years? This is a minus, in my opinion, and is a plus for the oral administration. Certainly, once again, the future and the hope that the new monoclonal antibodies that will allow us to have a monthly injection, as it was Zomita years ago, a monthly injection might represent another alternative to the IMiDs treatment and the maintenance approach. This was the last one. Thank you very much.